Secondary bacteremia, which refers to seeding of the bloodstream related to a localized infection, such as bacteremia associated with pneumonia, is a common and potentially life-threatening complication. Community-acquired bacteremia, pseudobacteremia. Isolation of bacteria from a blood culture does not invariably represent bloodstream infection. Bacteremia with organisms that normally colonize the skin, including coagulase-negative staphylococci, bacillus species other than Bacillus anthracis, Corynebacterium species, Cutibacterium acne or Micrococcus, may result from a non-sterile blood draw representing contamination. The significance of a positive culture with one of these low virulence organisms should be interpreted in the context of the clinical presentation. Growth from a patient with a prosthetic device or implant or isolation in multiple sets of blood cultures may suggest pathogenicity. Key point: bacteremia with organisms that normally colonize the skin, including coagulase-negative staphylococci, Bacillus species other than Bacillus anthracis, Corynebacterium species, Cutibacterium acne, or Micrococcus may result from a non-sterile blood draw representing contamination.
Gram-positive bacteremia. Staphylococcus aureus bacteremia. Isolation of Staphylococcus aureus in a blood culture is always considered significant and requires evaluation to differentiate uncomplicated from complicated infection. Patients with Staphylococcus aureus bacteremia require a thorough clinical evaluation to exclude sites of metastatic infection, particularly septic pulmonary emboli, septic arthritis, or spinal osteomyelitis or discitis. The latter two sites may require surgical intervention. Source control often involves removing infected prosthetic material or draining a loculated infection. In patients with Staphylococcus aureus bacteremia, infectious disease consultation should be obtained. The frequency of endocarditis among patients with Staphylococcus aureus bacteremia is as high as 30%.